To AETCM and the Emergency Medicine Channel. A 33-year-old male without any known comorbidities came to ER with complaints of difficulty to void since 2 days and bilateral lower limb weakness since 1 day. Patient on initial 10-second assessment, airway was patent, patient was speaking in full sentences. Breathing, respiratory rate of 80 with a saturation of 96% in room air. Circulation wise, BP of 140/80 with a heart rate of 90 per minute. Disability wise, GCS was full, E4, V5, M6 with pupils bilaterally equally reactive. Exposure wise, patient was afebrile and a GRBS was 105 milligram per deciliter. On adjuncts to primary survey, we had taken a VBG to look for the potassium in the patient. There was no any acid-base abnormalities and there was no electrolyte imbalance. Coming to sample history, patient was initially apparently well 2 days back when patient presented with difficulty to void urine, which was acute in onset, progressed to initially difficult to initiate and then able to void drops later by next day morning. Able to void drops. Later, next day morning, he developed difficult to even void drops with abdominal distension. Hence, he consulted urology department, got evaluated, and a 14 French catheter was inserted and was advised further evaluation.
So, what does that history tell you? Patient was having progressive difficulty in voiding urine, isn't it? So, and patient, what are things that you will suspect there?
Initially difficult to void, then went into retention. Progressive.
What is your case? Your case is bilateral lower limb weakness, right? And you want retention. So, your patient is telling that I had difficulty in passing urine. Is it difficulty in passing urine or is it difficulty in initiating urine?
Initially initiation, followed by retention. Like later he was not able to void at all. Initially,
So, at that point of time, what are the questions you need to ask the patient? One is, could you initiate urination? That is very important. If the patient is telling, yes, I want to pass urine, but I can't initiate, what does that mean? Patient's somatomotor reflex to the bladder is affected. See, initiation of urination is your somatomotor function. So, if somatomotor fibers to the bladder is affected, you will not be able to initiate urination. But will patient have retention and not able to pass urine at all? Patient will
be able to pass on applying pressure.
No, patient's bladder has what and all innervation? Autonomic and somatomotor innervation. So, somatomotor innervation is how you can initiate bladder voiding. Okay. So, if patients, there is a level like from L2 and above, if there is a lesion, somatomotor fibers to bladder is gone. That means patient will have difficulty to initiate passing urine. But there is autonomic innervation to bladder and autonomic innervation triggers urinary response at bladder distension. So, when bladder is distended to a prefixed level, autonomic nervous system automatically passes urine. So, patient will have difficulty in initiating urine, but patient will always pass urine when patient feels the urge to pass urine. But what if patient is having a lower spinal cord lesion, for example, like sacral region, S2, S4. Why S2, S4 levels? S2, S4 levels is where autonomic supply occurs. So, a supply at that level, if it is occurs, what happens?
Relaxation won't happen. Go into retention. Patient basically.
Patient will go into something known as flaccid bladder. Bladder will be like, it will not be able to contract and pass urine. So, patient bladder will overflow. Patient bladder will keep on distending till it overflows and patient passes urine. So, patient has no response, patient doesn't feel the bladder distension, and overflow incontinence is what you get. That is called as flaccid uterus, flaccid bladder. The other one, where there is difficulty to initiate urination, but at fullness, patient automatically bladder contracts and passes urine, is called as neurogenic bladder. Human bladder or neurogenic bladder. Okay. So, these are the questions you need to ask the patient, can you initiate to pass urine or not? And if patient is telling I can't initiate, then the question is, do you feel like your bladder is full? And when you feel bladder is full, is it automatically voiding? So if patient says yes, you are looking at a neurogenic bladder. If patient is telling I don't feel like urination, I can't initiate urination, but sometimes it just passes away without my knowledge, you are looking at a overflow incontinence, that is a flaccid bladder. Okay.
He consulted the urology department and he was catheterized. Next year, patient developed bilateral lower limb weakness, which was acute in onset, progressive. Patient had difficulty in getting up from the chair, difficulty in squatting, and history of buckling of knees. There was no difficulty to wear chappals. There was history of tingling sensations over the both legs and history of band-like sensation around the umbilicus. There is no history of any upper limb movement, no history suggestive of any cranial nerve deficit, no fever, rash, weight loss, any night sweats or evening rise of temperature.
Why fever, rash, weight loss and night sweats you asked in this patient?
To rule out tuberculosis, sir, because
Okay, rule out tuberculosis because?
Because one of the most common diseases here is tuberculosis in India.
Okay,
Which can
it will
port
cause
spine.
port spine. So, compression to the spinal cord causing spinal cord lesions or spinal cord compression is what you are looking at. Okay, then any history of fever is important, otherwise
Any abscess, any spinal cord abscess or anything.
spinal cord abscess is possibility.
Any malignancy also if there's an immunocompromised, fever, weight loss history.
Okay, malignancy. Other than that?
Viral, like any other infection which... Any
Post-viral infection causing myelopathy is one of the other causes of spinal cord lesions, right? So, any recent history, not currently, but any recent history of upper respiratory tract infections or gastrointestinal infections can be looked into. Okay.
He is not allergic to any known substance. There is no past significant medical history, not on any regular medications. Then we went ahead with examination. Systemic examination, respiratory system, cardiovascular system, abdominal examination are all within normal limits. Coming to CNS examinations, his higher mental function was conscious, oriented to time, person, place. He was obeying verbal command. Cranial nerve examinations were within normal limits. Then we went ahead with the motor system examination. Motor system examination, bulk in bilateral upper limb and lower limb was normal. Tone was normal. Power in upper limb was normal, both upper left and right, 5/5. Coming to lower limb power examination, the power was 4/5 in both lower limbs. With the plantars were flexor.
In all muscle groups, power was 4 out of 5.
Then plantars were flexor.
What you expected in power? You expected power to be from your history?
Lower limb weakness, paraparesis low.
Yeah, but from your history, you had difficulty in squatting, difficulty in standing up from chairs, but no difficulty in wearing chappals, right? So, history-wise, it was a proximal muscle weakness, but on clinical examination, you are getting power 4 out of 5 in all bilateral lower limbs, in all areas, all muscle groups. Okay.
Then coming to deep tendon reflexes, upper limb reflexes were within normal limits, biceps 2+, triceps supinator with 2+. Lower limb reflexes, knee jerk in bilateral was 1+, and ankle jerk was absent.
Okay, so you have got diminished deep tendon reflexes in the lower limb. Okay, what is the root value of ankle jerk?
Ankle jerk is S1, L5S1.
L5S1, knee jerk?
L2, L3, L4.
Okay. So, you are looking at a lesion level that is definitely above L5, L4. Which might have involved L2, L3, L4 because you are getting still a 1+ reflex in knee, right? Okay.
And so, coming to sensory examination, joint position sense and vibration sense were within normal limits. And then there was a definite sensory level at around the umbilicus, below which patient was not able to feel sensations.
Complete absence of sensation or decrease in sensation?
Diminished sensations. Right?
Diminished sensation. So, it's a paraparesis. Okay.
Then cerebellar signs were absent, sir. Gait, patient was having difficulty in walking, so not assessed. No signs of any...
What was the difficulty patient faced while walking?
Basically, patient while walking there will be buckling of knees.
Okay.
And then like if you leave him, he walked with support. If you leave him, he will fall down, and it will be very difficult to make the patient
Okay.
get up.
So difficulty in walking itself is there.
Yeah.
Okay.
Okay. Then all routine examinations, routine investigations, everything was sent. Along with that, we went ahead with an MRI of the patient, MRI brain with MRI whole spine screening. We went ahead with MRI. The MRI showed MRI brain was normal, whereas MRI.
Why did you do MRI brain?
MRI brain because sir, there are
What is your
rare
presentation?
conditions.
Bilateral lower limb paraplegia. Paraparesis with the paresthesia.
Yes.
Do you think there is a lesion in brain?
No, very rare. Causes are
What
very
if at all a lesion in the brain? What should be the presentation?
that should be the best. Hemiparesis. If brain usually
Brain
one-sided
is
weakness.
hemiplegia, hemiparesis. If bilateral weakness is there, we are looking at a
Spinal cord.
motor region lesion. If bilateral meningioma,
No, if
parasagittal meningioma is there, but it usually affects motor area only. You won't get bilateral paresthesia and paraplegia. So when paresthesia and paraplegia, especially when head and face is not affected with sensory levels, you should suspect spinal cord early. Here, you definitely do not have face and head, right? So you are looking at a lesion in the spinal cord. So MRI spinal cord is most important here. What was MRI finding?
MRI showed some linear T2 bright signals were seen involving the dorsal cord at multiple levels. The suspicion of any demyelination or myelitis was considered after the MRI.
Only in dorsal cord.
In dorsal cord.
What is the problem?
Joints and
What was our clinical finding?
position sense, and this was normal.
Our clinical finding was patient's position sense and vibration sense was intact. Position and vibration sense are conducted through dorsal column. Posterior column conducts joint sensation, vibration sensation. So if multiple levels dorsal column is affected, our position and vibration sense should be significantly impaired, and there should be a sensory level for posterior column. And what did we get? In our sensory examination, we got a very clear sensory band-like sensation at umbilicus, that is T10 dermatome. So around the T10 dermatome, we have a sensory level. So that means, what is the spinal level lesion we are suspecting?
T8.
Two lesions, two levels?
Above.
Two levels above. So T8 level. T8 level is the lesion we are suspecting. But spinal level means what? What tracts are involved? Spinothalamic tract. So we are looking at a spinothalamic tract involvement, which takes up fibers for fine touch, pain, temperature, isn't it? These are the impulses that is taken by spinothalamic tract. So spinothalamic tract bilaterally affected with the sparing of dorsal column is usually seen in which condition? You have spinal cord lesions, then divided into syndromes, right? Spinal cord syndromes. So you have different parts of spinal cord that get affected due to different diseases which have varying presentation. So how can you affect spinal cord? You can have complete spinal cord involvement, that is not transection as such, segmental. Transection is said when there is trauma, when there is transection of spinal cord, where spinal cord is completely cut off. But other than trauma, when there is other causes, inflammatory or autoimmune conditions affected, it can be segments of spinal cord is completely affected. So there will be complete one level below the spinal cord where there is complete loss of motor functions, sensory functions and autonomic functions, and above the segment there will be normalization of spinal functions. That is complete. Then you have partial. So partial is then divided into multiple syndromes. One of the syndrome is Brown-Sequard syndrome, that is hemisection of spinal cord. Brown-Sequard syndrome is one of the rarest forms of spinal cord syndrome. It usually is happening in trauma. You get gunshot wound or stab injuries to the spine, in which spinal cord is half of the spinal cord is transected while the other half remains intact. So when you have brown circuit syndrome, what will be the presentation symptom of the patient?
Ipsilateral weakness,
Motor weakness of ipsilateral side.
contralateral pain and temperature loss.
Yeah, so contralateral spinal sensory spinal level with the ipsilateral weakness and dorsal column involvement, because dorsal column is crossing over at medulla. Normal fine touch temperature and pain crosses over at ventral horn, isn't it? Ventral horn, it crosses over 2 levels up. So ipsilateral dorsal column is cut off, ipsilateral corticospinal tracts are cut off, while contralateral pain and temperature will be absent. That is brown circuit syndrome. Will brown circuit syndrome has bladder involvement? For example, injury level is at T12. So half of spinal cord is gone. So you have descending autonomic fibers from the cortex, right? So will the patient have bladder involvement?
Sympathetic fibers from T10 to A2. So sympathetic fibers.
One half is paired.
Bladder's autonomic innervation is predominantly parasympathetic, not sympathetic. Question is, your T8 level, think T8, T10, doesn't matter, T8 level, you have a hemisection of spinal cord. So one half of the spinal cord is gone. So one half of descending autonomic fibers from cortex is gone. Will the patient have bladder involvement or not? Patient will not have, because bilateral innervation of autonomic innervation is from bilateral cord. So even if one side of autonomic fibers are cut off, the other innervation will make sure bladder functions are preserved. So bladder autonomic innervation is usually not lost in brown circuit syndrome. Okay, that is brown circuit. What are the other cord syndromes? Anterior cord syndrome. So what is anterior cord syndrome means? Anterior part of the spinal cord is affected. How? What will be the presenting findings? What are the anterior cord structures? You have ventral grey horn. We have the ventral grey horn. Then you have corticospinal tract on the lateral side, and you have spinothalamic tract. So patient will have bilateral. Patient will have a clear sensory level, because pain, temperature of bilateral pain and sensations will be cut off. Patient will have bilateral paraparesis will be there. Usually anterior spinal cord syndromes are caused by thrombus over anterior spinal artery. Anterior spinal artery. Anterior spinal artery is a single artery. Posterior spinal arteries are two, paired. So anterior spinal artery being single artery, if there is occlusion, 2/3 of the anterior spinal cord will be gone. So posterior spinal arteries give supply only to 1/3 of the posterior spinal cord. So 2/3 of anterior spinal cord means bilateral corticospinal tract and ventral gray zones will be gone. So you have pain level, bilateral paraparesis or paraplegia you will develop. But your posterior column sensations will be intact. That is, vibration sense and joint position sense will be intact. Then you have
Central cord syndrome.
You have central cord and dorsal cord syndrome. So anterior, then dorsal cord. Dorsal cord syndrome is
Loss of joint position sense and
yes, where the dorsal column is involved. Patient may or may not have corticospinal tract involvement. It depends on the cause of dorsal cord syndrome. What are the causes of dorsal cord syndrome? Most common is what? Demyelination is there, infection, dorsal column infections are there, vitamin B12 deficiencies will be there, compression can be there. So usually when dorsal column syndrome is there, posterior column will completely be occluded and patient will have loss of vibration sense and joint position sense. But what if it is a abscess that is compressing or tumor that is compressing? So there will be varying degrees of compression over the cord. The dorsal most structures will definitely be affected, but going to the lateral, patient may or may not have bilateral or one-sided corticospinal tract involvement. So if corticospinal tract involvement are there, the weakness will be according to the compression. Where the compression is more, there patient will have more features. So corticospinal tract, how is the fibers arranged? Lateral most is
Second.
lateral most
sacral.
is lower limb fibers. So upper limb fibers are medially placed, and lower limb fibers are laterally placed. So when you have a posterior mass that is pushing into spinal cord, if at all corticospinal tract is involved, the lower limb weakness will be much more than the upper limb weakness. So posterior column cut off with the lower limb weakness much more than upper limb weakness, we are looking at a
Dorsal column.
dorsal column. Why it is important is in central cord syndrome. What is central cord syndrome?
Central cord syndrome will cause weakness of both upper limb, lower limb, but upper limb more than lower limb.
Yes. So it is a expansive lesion from the inside of spinal cord. It is from inside of spinal cord the lesion is coming up. So it will affect the ventral horns. So patient will have patchy affection of sensory level. Usually it will be like wherever the sensation is affected, in that area the crossover fibers of that area will be compressed. So patient will have the segments in which the expansion lesion is there patient will have sensory loss. But above and below sensations will be preserved. So that is called as suspended sensory level. So one area, for example, lesion is at T8, patient will have T6 to maybe T8 or T9 level sensory loss. But above T6 and below T9 or T10, patient will have normal sensation. That is ventral horn involvement. Then posteriorly it can push into dorsal column involvement. In dorsal column, usually fibers of lower limbs will be affected first, and then you will have corticospinal tract involvement. In corticospinal tract, medially placed fibers are upper limb fibers. So upper limb fibers will be affected more than lower limb fibers. Okay. So this is central cord syndrome. Okay. These are the spinal cord syndromes as such that we are talking. Clinical presentations of the patient. Now, when a patient presents with the lower limb paraparesis or paraplegia in ER, how do you approach the patient? We told if head and face is not affected, we are looking at
Spinal cord.
anything
Which is
below
the face.
brain. It can be spinal cord,
It can be neuromuscular.
neurons, spinal cords, nerves arising from spinal cord,
Neuromuscular junction.
neuromuscular
muscle.
junction or muscles. So 4 levels are there. So in spinal cord, most common causes that is affecting spinal cord can be infection or other causes. So what is the most common infections that can present with the bilateral flaccid paralysis? Most common was in India was polio. But even now you should look for polio if you are dealing with children. There are 2 reasons. One is screening. We should never stop screening for polio because we want to know whether there can be vaccination. Our government is doing so much of vaccination drives, but there can be pockets of population in which vaccination is not properly done. In that case, there can be outbreaks of polio, which will be endemic. For that screening, we need to continue. Second is, it can be vaccine associated or vaccine derived. So vaccine associated paralytic polio is there or vaccine derived poliomyelitis is there. Very rare is vaccine related complications, but we need to look for it. This but only associated with the children. In adults to develop polio is very rare in India now. Okay, so polio is one thing, but clinically more than polio, what else can develop? Other polio like viruses. So enteroviral species. Polio is one enteroviral species. Other enteroviral species are there. Those viral infections can produce polio like
symptoms.
Flaccid paralysis. Usually polio is unilateral involvement, unilateral LMN weakness. That is why all polio patients has atrophy of limbs. But other polio like viral infections usually cause bilateral involvement. Polio usual presentation will be flaccid paralysis preceded by GA symptoms, fever and GA symptoms. But other enteroviral species, it's upper respiratory syndrome followed by bilateral flaccid paralysis. In India, it's very rare, but in Western countries, enteroviral infections are there. What other infection we should suspect?
Viral infections, basically viral infections such as mycoplasma, measles, varicella, post-varicella, EBV, Zika virus.
Zika virus is another new virus that has recently come up. Not recently, but something that has come up in 2016-18, right? 16-18. Zika virus also had bilateral flaccid paralysis. So these are the infectious causes we should suspect. Okay, now coming to myelopathy, isn't it? The diseases that affect spinal cord as such. What are the diseases?
Well, one could be direct trauma to the spinal cord.
Correct. Trauma is the first thing we should suspect, and it's most the easiest one to suspect, isn't it? If trauma is there, spinal cord injury with the trauma is there, what is one additional clinical symptom you should suspect or you should look for?
Clinical symptom. That is not trauma.
Is not trauma, right? In trauma, if like we told spinal cord syndromes, not lot of clinical features we told. Like in traumatic spinal cord injury, what is one clinical condition you should look for?
Spinal shock.
Not spinal shock, neurogenic shock. What is spinal shock? What is spinal shock?
Phase of human palsy, which the
Initial phase of element palsy. When there is acute spinal cord injury, when there is like a transection of spinal cord, brown circuit spinal cord or transverse myelitis. In these conditions, there will be acute de-innervation of the associated motor neurons causing element type paralysis. Which will always progress to human type paralysis. That is the difference between spinal injury. Spinal injury, you will always progress towards human palsy, but that progression might require days to weeks. Between that days, when the patient acutely present, you may feel that you are dealing with a element type paralysis, where there is absence of DTR, deep tendon reflexes, hypotonia and areflexia. Because of this, that is called as spinal shock. But when you are dealing with the trauma, you are looking at neurogenic shock. That is due to absence of sympathetic outflow. So usually which areas are you looking at? Which spinal areas of trauma are you looking at if you are dealing with a spinal cord trauma with hypotension? Refractory hypotension, and you are ruled out all hemorrhagic causes. What level are you suspecting spinal cord injury to be? Cervicothoracic level. Ideally from T6 level and upwards. T6 level is where heart innervation is finishing off. So T6 and upwards should be the spinal cord injury to produce a neurogenic shock. Okay, so that is traumatic spinal cord injury. Neurogenic shock is additional clinical feature that you should look into. Okay, what else?
Other than that, sir, infections, neoplasms.
Post infection causing myelitis, similar to
Transverse myelitis.
Transverse myelitis.
Then it could be due to any multiple sclerosis.
Inflammatory conditions.
Demyelinating conditions.
Multiple sclerosis.
Then any neoplasm.
Neoplasm. That is compressive myelitis.
Compressive myelopathy.
Compressive myelopathies can be neoplasms.
Could be any abscess.
Abscess.
Could be any tumor, hematoma, tumor.
Hematoma. You have anterior spinal artery, posterior spinal arteries. You can have epidural abscess. All these are extraaxial mass lesions that is going to compress the cord. Compressive myelopathies can develop, and one of the compressive myelopathy is IVDP, intravertebral disc prolapse, is it? Okay. IVDP usually causes what type of spinal cord syndrome? Usually IVDP occurs below at L4, L5 level, so you never see spinal cord syndrome in IVDP. Isn't it? Most common is L3, L4, L4, L5, L5, S1 levels. All that levels you don't see spinal cord syndrome, right? Why?
This compressive nerves, exiting nerves.
There is no spinal cord there. Spinal cord ends at the level of L1, base of L1. Spinal cord ended. So all those are nerve root. Because of that, IVDP will not have classical spinal cord syndrome. So if patient has IVDP and classical spinal cord syndrome, you are looking where? You are looking at cervical spine IVDP. You can have disc prolapse at cervical level. No? In cervical level, anterior spinal cord compression is there, you will have IVDP causing. Otherwise, lower part, it is always patchy involvement as per the spinal roots that are compressed. Okay. So that is compressive myelopathy. Now, what is the other things?
Then coming to peripheral nerve diseases.
So, now coming out of the spinal cord to the nerves that is presenting. What are the most common?
Most common is GBS.
Most common is GBS. Okay.
Then any tick paralysis, diagnosis of exclusion.
Tick paralysis is very unlikely. What else? Some other medical complication. Patient will have severe abdominal pain.
Lead poisoning.
Yes. Neuropathies will come. Correct. Okay. Anyhow, you started. So, you also told. So, AIP, acute intermittent porphyria, will develop neuropathy causing sensory loss as well as motor loss. Usually it is motor loss more than sensory loss, but AIP is a possibility. So patient will have previous history of similar episodes which improves over time, and severe abdominal pain will be there. AIP is a possibility. Then as you told, it can be neuropathy due to toxins or deficiencies. Deficiencies are B6, B12 deficiency and toxins. What are the toxins?
Organophosphorus.
Organophosphorus is not nerves, right? Organophosphorus is NMJ. So leave organophosphorus. Others are lead, thallium, mercury, all these. Heavy metal toxicity we can suspect. So all these things affects neuropathy. There will be varying degree of motor as well as sensory neuropathy, but motor predominantly than sensory. Okay. So heavy metals. What else?
Neuromuscular junction.
You have coming to in emergency you can come to neuromuscular. Otherwise you can have motor neuropathy. Acquired polyneuropathy can be motor and sensory neuropathies. But in emergency medicine, it's rarely we go that deep into the diagnosis of that. Let's go to NMJ. What are the NMJ conditions we should suspect?
One is myasthenia gravis.
Myasthenia gravis.
Then organophosphorus or carbonate.
How does myasthenia will present usually? Will the patient have flaccid paralysis?
No, it will be
Patient can develop with flaccid paralysis. Patient was not treated and presenting to you very late. But history will always be progressive weakness with the exertion.
Yeah.
So if the patient has presented to you from outside hospital, not treated properly, patient was having exertion, that exertion induced element type of weakness you can see. But it's very rare. Usually patient will tell you, I had progressive weakness over prolonged period of time. Okay, so myasthenia. Then what else?
Then organophosphorus or carbonate.
Organophosphorus. Botulism.
Snake venom, snake poison.
Snake envenomation, that you have to say. In India, snake envenomation is the most common flaccid paralysis. You can get patients, usually young patients or even middle-aged patients, presenting to you with patient went to sleep normal. Today morning he is not getting up. He is conscious, he is oriented, he is talking, but he can't move his lower limbs. Or he can move all four limbs, and it is progressively worsening. When you check, it will be element type of weakness that is having, but there won't be any sensory level involvement. Sensations and posterior column and anterior column will be completely fine. So that can be snake bite, because in India very likely patients can be bit by snake when they are sleeping. So neurotoxic envenomation. What are the neurotoxic snakes that we have in our country? What are the neurotoxic snakes we have in our country? Cobra and crate. Cobra and crate. Yeah, cobra and crate. So most commonly is associated with the wet areas. Cobra is in paddy fields and wet areas, while crate can be seen in a variety of conditions. In southern states, cobra bite is more common than crate bite. Progressive symptoms, so patient may not remember when the bite has happened. Okay. So NMJ.
Then coming
And
to muscle,
muscle.
as such, muscle could be, sir, any alcoholic myopathy, any
Myopathies, all myopathies.
periodic
Alcoholic,
paralysis,
alcoholic, then
myositis.
inflammatory myositis, isn't it?
Yes.
So alcoholic myopathy, inflammatory myositis, all this cause, will it cause paraplegia or paraparesis? Patient will not have weakness. Patient will have difficulty in movement mainly due to
Tenderness.
pain. Muscle pain will be the thing. Difference is periodic paralysis. Periodic paralysis, patient will have pure weakness. It's not muscle pain. Patient can't move. So what are the periodic paralysis that you know?
Hypokalemic,
Hyperkalemic, thyrotoxic. These are the most common that you say. When will you suspect hyperkalemic periodic paralysis?
usually after an exertion, like patient has history of walking very long distance, going on a trek, rich carbohydrate diet in the night.
Rich carbohydrate diet and exertion. Hypokalemic periodic paralysis. Hypo.
Hypo is this.
Hypo is also rich carbohydrate diet and exertion. Hyperkalemic can be rich carbohydrate diet and even at rest it can happen. Stress it can develop. That is the difficulty. You may or may not get precipitating factors. And multiple previous episodes will be there because this is genetic condition. A very unlikely patient will present it to you at 25 or 30 years of age with periodic paralysis. Before that, patient will have history. Okay, so these are the levels in which we can approach the patient, what the patient is having, right? So finally, in ER, if you have this patient, so you have multiple DDs according to the levels, and you have the spinal cord syndromes in which you can assess the level of spinal cord. How do you proceed? All these cases, whatever be, how do you proceed with the patient?
So initially we have to go with the labs.
You want routine investigations because you want to rule out all periodic paralysis, you have to rule out, so thyroid and potassium levels you want. Otherwise also you want to get a electrolyte profile to see whether any other electrolyte abnormality which is supporting the worsening the clinical features are there. You want to see infection, inflammatory parameters you want to send to look for any ongoing infection. What else?
Serum CK level if polymyositis is
yes, total CK levels to look for polymyositis or rhabdomyolysis. What else?
Ultimately MRI to...
Once that, all these things is to rule out conditions. But if you want to diagnose, that is rule in condition, you have to go for imaging. So the best imaging that you need to go for is a MRI with contrast. MRI whole spine with contrast. Why whole spine? For example, in this case, you have got a T10 sensory level. So we know it is going to be at T8 lesion is what we know. So you just want a MRI thoracic spine with contrast, right? Why you want whole spine?
Multiple demyelinating lesions.
Multiple segments of demyelination or ongoing demyelination will be there. So you want to take MRI whole spine with the contrast for these kind of patients. And if your MRI spine is normal, unless the patient gives his history of classical GBS, if your MRI is normal, your next investigation is going to be nerve conduction study. Unless patient gives classical history of GBS, then nerve conduction study will take predominance over MRI because rapid onset will be there. You have very little time before patient may require ventilatory support. So nerve conduction study will come into play. But if no classical GBS features, MRI spine with contrast, following which if MRI spine with contrast is normal, you go for nerve conduction study, NCV study. Okay, all this is well and fine. You call up neuro, patient requires admission, may require IVIG treatment and all. Let's don't go into that because emergency don't get into these things. What are the red flag signs in these patients that an emergency physician has to take care?
First of all, if it's an ascending paralysis, if you're suspecting ascending paralysis, then whether patient is respiratory muscles are affected, diaphragm is affected or not.
So breathing. Usually airway is not an issue, right? We are not looking at an airway problem, we are looking at a breathing problem. So here, whenever you get a paraplegia patient or a paraparesis patient, In breathing, in ABC, breathing, you have to assess whether patient is having bilateral equal chest wall
Stress.
movements, is breathing effort adequate. Ask the patient to take a deep breath and see whether he can do. It can be very well be myasthenia, right? A patient will be having difficulty in taking deep breath. When you ask, patient will be having shallow breath. When you ask deep breath, patient will say, I can't. Patient will be tachypneic. Patient will have difficulty in speaking because more demand is there. Tachypnea will be there. Very rarely patient will have deoxygenation. Very rarely patient will have deoxygenation because there is no problem in oxygen CO2 dissociation. The problem is with the muscular movements. So patient saturation will be very normal till it is not normal. Then it will rapidly fall. So the idea is to look for patients who is prone for progressive respiratory paralysis and initiate on ventilatory support as soon as possible. If it is myasthenia, it is very treatable, very early treatable. You can even start with NIV to support their respiratory effort to decrease effort-induced paralysis. But any snake bite or any ascending spinal cord syndromes or traumatic spinal cord syndromes, it's most probably patient will require ventilation. Now, we told ventilatory paralysis, right? Respiratory paralysis, right? What level of spinal cord injury will require ventilatory support?
See, sir.
Two, C2, 3, 4.
Any level
C3,
above
C5,
C4,
C3,
above C4 will require ventilatory support because phrenic nerve. Phrenic is
Diaphragm.
C4,
C3,
4, 5, 6. So any level above phrenic nerve, definitely patient will require ventilatory support, and it will be acute onset respiratory paralysis. Patient will go into hypoxia, apnea, and death. You require emergency intervention. But any level below C4, phrenic nerve will be partially involved. So patient may have initiation of breath, but will be difficult and will eventually require ventilatory support. Any level below C6, patient may not require emergency ventilatory effort, but patient can still go into respiratory paralysis. How? What is phrenic nerve supplying? Phrenic supplies diaphragm.
Yeah.
But is diaphragm the only respiratory muscle? You have intercostal muscles. So the intercostal muscle is innervated by intercostal nerves. So intercostal nerve involvement is there also. Patient can go into progressive weakness, especially if patient is having tachypnea. Because when you have tachypnea, is your intercostal muscles more required, isn't it? So any spinal level above T12, you have highly likely to develop respiratory weakness. Low from thoracic vertebrae, lower the lesion, less likely you develop because more intercostal muscles will be acting. But a thoracic level spinal lesion also you should suspect. Patient might require respiratory support. So that is your first red flag. What is the second red flag? One more thing. How can you see whether patient is going into respiratory failure?
Baseline PCO2.
So you can take a ABG at the beginning and see for baseline PCO2, and when you see patient's respiration is worsening or effort is worsening or patient is going to shallow breaths, you can take another ABG and see whether PCO2 is worsening. But it's usually eyeballing. If you see patient is worsening, you know patient is going into this. You really don't want a secondary ABG to say, oh, patient requires intubation. It's just for documentary purposes, which is not necessary. What is the other thing that you can do?
Single breath count.
Single breath count. This is the most common test that we do in
Snake bite.
in snake bite, myasthenia, isn't it? Snake bite, myasthenia, Guillain-Barré. This is the most common test that we do in ER. Not at all invasive. Patient can very well do. Problem is operator bias. Unless you do the test properly, one person will get one value, another person will get another value. Operator bias is the only problem here. So red flag number 1. What is red flag number 2? Hypotension or autonomic dysfunction. So this is but much more common only in traumatic patients when you get a neurogenic shock. Other spinal cord lesions unlikely to develop neurogenic shock as such, but autonomic dysfunction can happen. So first let's see neurogenic shock. That is complete cutoff of sympathetic outflow. Patient will go into hypotension due to
sympathetic outburst,
vasodilation. There is no vasoconstriction happening, so vasodilatory shock. Patient is in neurogenic shock. What is the drug of choice? Noradrenaline. Drug of choice is noradrenaline, except when patient has hypotension with the bradycardia. When hypertension with bradycardia, drug of choice will be dopamine. Otherwise, drug of choice for just neurogenic shock is noradrenaline. Okay, so done that. Now spinal cord lesions, as we told, transection or transverse myelitis, everything can cut off autonomic fibers coming from cortex. That can cause autonomic dysregulation. How will the patient present? Varying degrees of
heart rate,
varying blood pressure, varying heart rate will be there. But unless patient goes into severe bradycardia, we really don't have to manage it. Okay. These are the two major red flags in ER. We need to support the patient, because if we miss these, patient can go into significant complication. Now, what is another couple of things that we need to support the patient when patient is under our care?
Catheterization.
Foley's catheterization, because if at all human bladder, at least patient will pass urine, even though he can't initiate. But if it is LMN bladder, patient will not, or bladder will over distend. We don't want that. So catheterize the patient.
DVT prophylaxis.
DVT prophylaxis. Alphabet. Raise to feeding. Patient may not have difficulty. If it is lower spinal levels, patient will not have any difficulty in swallowing. But upper spinal levels, if patient is having difficulty in swallowing or ascending weakness is there, we put a rise tube also for the patient, and prevent constipation to the patient too, including bladder innervation. Anal sphincter innervation will also be gone. So patient can have incontinence, which is fine, but constipation should be prevented. Anything else?